Hi, Sardar. Thank you for inviting me.
Thank you for just coming here to give your experience on goal-directed perfusion. Thank you.
Yeah, I'm excited to participate. I'm disappointed I can't be there in person in Greece. It would be very nice. I think ever since Dr. Gibbon first used cardiopulmonary bypass to fix an ASD in 1953, we've been trying to figure out the best way to manage our patients while they're on this black box. And I think it's societies like yours and conferences like these that help advance our field and help us figure out the best way to take care of our patients in the operating room. I'm going to talk mainly about goal-directed perfusion. I'm going to do my best to give it some justice in 10 minutes. Mainly that's going to focus on DO2 or oxygen delivery. I do believe that DO2 is important. I think there's a lot of data that shows it's important, but I believe that it's not the only variable that's important. And I think we don't fully understand where it fits for our patients on pump. I'm going to try to convince you that pump flow is the major lever that should be adjusted to improve oxygen delivery on pump. I'm further going to try to touch on the point that I don't think we should be transfusing patients to treat anemia or to solve low DO2, mainly because of the side effects of transfusing a patient are exactly what we're trying to avoid by improving oxygen delivery. And I'm going to try to touch on the fact that perfusion pressure, as we all know, is a very important aspect of end organ tissue oxygenation on pump. Back in 1964, Jack Crowell published this paper, which showed that inadequate oxygen delivery increased mortality for patients in shock. And in fact, as far back as the 1930s, people were publishing bench work showing that an oxygen supply-demand mismatch created end organ tissue ischemia and had adverse effects. More recently, in cardiac surgery, there's been a number of good studies, and we don't have time to go through all of them, but I picked a few to try to highlight. One of the best, I believe, is Marco Ranucci's randomized trial looking at goal-directed perfusion and showing increased acute kidney injury for patients who did not have adequate oxygen delivery on pump. There are a number of experts in the field involved in this study, including Robert Baker and Richard Newland and others. This is a very good study. Another randomized trial published last year from the Tokyo group also showed an association with inadequate oxygen delivery and acute kidney injury. And then this paper from the University of Pennsylvania and Trent Magruder is not a randomized trial, but is an analysis of over 800 patients where they stratified their outcomes in acute kidney injury as well as other postoperative complications by oxygen delivery, hematocrit, nadir hematocrit on bypass, mean arterial pressure on bypass, and pump flow. And they tried to look at which variables were most important. What were the results of these trials? First of all, these three trials all targeted a threshold DO2 of 280 to 300 milliliters per minute per meter squared. And in general, in the literature, that's where people have landed. There is some variation on that. So we haven't settled on the exact DO2 threshold that's important, but there's a general consensus. All three of these studies showed increased AKI when you had inadequate oxygen delivery or dropped below 280. However, they all, and most of the studies in the literature have showed that, although they haven't all shown that there's an association with AKI. And the association is almost exclusively with stage 1 AKI. That's not true for every study. It's true for these three studies and for most studies. And in fact, even when you dig deeper into these trials, there's a little bit of weakness in the relationship between DO2 and AKI. For example, in the Tokyo randomized trial, there was an association in the raw data, but if you do a multivariable analysis on their data, DO2 is no longer an independent predictor of AKI. In fact, the only predictor is pump time. And if you look at Magruder's trial, there was actually no association with AKI in the overall population of 834 patients. But if you took out all the isolated CABGs and just looked at the non-isolated CABG patients, then there was an association with increased AKI and inadequate oxygen delivery. Magruder's trial also looked at other postoperative complications and interestingly showed an association between inadequate oxygen delivery on pump and prolonged ventilation postoperatively, which in the States is defined as more than 24 hours of mechanical ventilation. They showed no difference in mortality or other complications in any of these trials. And that's true for almost all of the trials on DO2. This is another excellent study on DO2. This is from Richard Newland and the Perfusion Down Under group. This is a real world registry, which is always extremely valuable, 19,000 patients. And they were looking, they developed a predictive model for AKI and they looked at threshold DO2. And they settled on 270 as the threshold. And the way they did this was they plotted out their raw data and they tried to optimize sensitivity and specificity, and that landed at about 270. Interestingly, if you look at the sensitivity and specificity at 270, it's still really only modest if you're using DO2 only as the predictor of AKI. And the other thing before I move on, in this trial, if you look in table 2, where they did their multivariable analysis of what independently predicted AKI, there were a number of other variables. DO2 was a predictor, but so were a number of other variables that we're all familiar with: age, comorbidities, heart failure, redo surgery, emergency surgery, non-isolated CABG. So there's more to the story, this seems to suggest, than just oxygen delivery. Time on pump was also an independent predictor in this study. These are our data at University of Maryland, St. Joe's, looking at 1,000 patients and stratifying outcomes by oxygen delivery. We looked at a DO2 under 280. The yellow bar are patients that had more than one DO2 less than 280 while they were on pump. And when we did a multivariable analysis, the only thing that correlated as an independent association with DO2 was prolonged ventilation, which is similar to Magruder's trial. We found renal failure and AKI correlated in our univariable analysis, but it fell out as an independent predictor. We also found that our patients with low DO2 tended to be higher risk patients with more comorbidities. We also had a high proportion of patients with isolated CABG in our cohort. So very similar results, I think, to the Magruder and the Penn group analysis. And this study is in press, will be available shortly. If you dig a little deeper into the Magruder trial, which I think is a very interesting analysis because they looked at oxygen delivery, flow on pump, hematocrit, and mean arterial pressure, and they tried to tease out the independent association of each variable. And what they concluded was that the trends in their data suggest that low flow on cardiopulmonary bypass appears to drive the adverse effects of low oxygen delivery, as well as possibly hypotension. So in their study, flow correlated very well with the significant outcomes once they took isolated CABGs out of their population. But they also found that mean arterial pressure correlated very well with complications. In fact, mean arterial pressure dropping below their threshold was correlated with mortality in the study. But they did not find that anemia correlated with outcomes. And this actually agrees with Ranucci, who in his 2005 study looked specifically at nadir hematocrit on bypass, as well as oxygen delivery. And he found very specifically, what he found was that nadir hematocrit on bypass did correlate with acute kidney injury. But if he corrected those data for the patients that got transfused, then nadir hematocrit no longer predicted acute kidney injury, meaning that it was really the patients getting transfused that had the acute kidney injury, not the overall anemic population. And then he looked at how oxygen delivery correlated with anemia as far as acute kidney injury. So, and I think this is very instructive for people that are managing patients on pump and want to avoid acute kidney injury. If you look at these bars, so on the horizontal axis, there's 4 groups. And on the y-axis, you have your incidence of acute kidney. Actually, this was acute renal failure he was looking at. So in this study in 2005, he looked at acute renal failure requiring dialysis post-op. So this is one of the few studies that was looking at actual hemodialysis as an outcome. And the first 2 groups, the kind of 2 lighter bars, are both groups that had high oxygen delivery. So they kept their DO2s over 280. The 2 black bars had DO2s less than 280 on pump. And then for each of those 2 groups, there's a high hematocrit group on the left and then the low hematocrit group on the right. And what you see, first of all, is if you have a low hematocrit, but you're able to maintain a high oxygen delivery, then there's no statistically significant difference in acute renal failure. So that means that if you have an anemic patient on pump and you're able to turn up your pump flows to maintain a DO2 of 280, you will not have a statistically significant difference in renal failure from a patient that does not have a low hematocrit. On the other hand, if you have a patient with a high hematocrit, but a low oxygen delivery, so inadequate pump flow, you will have a statistically significantly increased chance of requiring dialysis after surgery. And then this also shows that low flow is exacerbated by having a low hematocrit, because then your DO2 is even lower. But this graph suggests that it's pump flow that we should be using to adjust oxygen delivery and try to optimize oxygen delivery. And that those units of blood that we use to try to solve the anemia and improve oxygen delivery are also delivering acute kidney injury when we transfuse. So what can we do? What would we recommend regarding oxygen delivery? I don't think the final recommendations have been written on this, but if I had to come up with recommendations now, I would say number 1, treat preoperative anemia aggressively. Since anemia is a problem, but we know a blood transfusion is a bigger problem, try to avoid going into the operating room with anemia, and don't treat it with a blood transfusion, but treat it with erythropoietin, IV iron, B12, and folate. No matter how much time you have, it's beneficial, even if it's just the day before. Limit hemodilution, which miniaturized circuits do very well, and I think is a good technique. You can also use retrograde autologous prime, venous autologous priming, cell salvage. You can use other techniques as well, like ANH, and you can use these techniques in combination if you're facile with them. Target DO2 around 280, but do so by increasing pump flow. And finally, I would advocate not to transfuse packed red blood cells to treat anemia, because it's a situation where the solution can be more harmful than the problem. Thank you.
Thank you very much, Ron. So, with this great presentation. So, I'm here with Dr. Nalbanti, intensivist from Greece, and Dr. Murkin, anesthesiologist from Canada, and they will probably ask some questions.
Thank you for your presentation. Maintaining the optimal DO2 through fluids, inotropic agents, or vasopressors is crucial for the patients and very important for us in the ICU. As intensivists, we don't know about all this, about perfusion in the operating room, but we face all the result of them. When the perfusion is right and the surgical procedure is the best you can, for us, we have to face less complications and the outcome of the patient is the better it could be. Thank you.
Thank you. John?
I think that's a very important recommendation, the pump flow to increase oxygen delivery. I think we've known for a long time, as you point out, the adverse effects of allogeneic transfusions, and whatever we can do to avoid that is key. And understanding, again, that we need to provide sufficient substrate delivery to tissues by increasing pump flows where possible, I think is a major, what's the word, important aspect that I don't think we've emphasized enough, which goes along with all of the other steps to try to avoid the anemia in the first place. As you say, that's part of the ERAS program, trying to optimize hemoglobins before we get started. And similarly, the limitation of anemia, of hemodilution. And certainly for, I think, most anesthesiologists these days, I think, are very tuned into this to try to minimize the amount of fluid, exogenous fluid administration. And similarly, miniaturization of the circuit, so all of these components together. But I think, as you've identified, it's as much the actual transfusion itself that I think is harmful, and that's been a message that's been out for quite a while, and the ability to understand that and focus on other strategies is important. So, yeah, thank you.
Thank you. And Ron, I also asked Mike before, so since this society is minimally invasive extracorporeal society, circulation society, so I want to ask, we always discuss about the low penetration rate of the MIEX systems in the US. As a surgeon, what do you think about that? What are the barriers, or why is it like that?
Well, I think you're right. I don't know why in the US it's not one of the techniques that have been more adopted. The people have gone to using smaller tubing, but that's not exactly the same as a miniaturized circuit. And I don't know if we need more data to show the differential effects of miniaturizing your circuit versus doing autologous prime versus ANH, for example, because there's probably 4 or 5 good techniques to avoid hemodilution. And one of the questions I wonder about is, are you better off just doing 1 or 2 of them aggressively, or should you be trying to do all of them, or which are comparatively more effective? And I think some data on that may increase the adoption of miniaturized circuits.
Thank you. And there's Dr. Ashrafi from Germany. He's a surgeon. He also wants to ask you a question.
Actually, I'm a surgeon and a critical care specialist, so I have a provocative question. I totally agree with flow, and flow is more important than your hemoglobin, and it's a matter of oxygen delivery. So when do you transfuse?
It's a good question. I have the answer for me, but I don't have the answer that I can say is 100% correct, because as Dr. Grant alluded to, we don't know the perfect physiologic trigger or threshold for transfusion. We only use anemia, which is really doesn't tell us what's going on inside the cells. So what we do at our program, we're very restrictive. So we essentially only have 2 indications to consider a transfusion, and they're not triggers, they're thresholds for a discussion. One is if a patient is actively bleeding, and as you know, I think that's the most justified reason to transfuse, but as you know, not all of those patients need to be transfused. Sometimes a prompt re-exploration will solve that problem. And then the other, if someone gets to a hemoglobin under 6, we consider a transfusion, but we try to look for a physiologic reason, like a base deficit or some other sign of real end organ malperfusion. And basically look at increasing lactate or increasing base deficit.
Thank you very much.
Thank you, Ron, for your presentation and talk. Thank you very much.
Thank you.